mamas. Thanks so much for joining us. This is one of our last sessions of the day. I can't believe the day has flown by. Thank you for joining Huddle Up Moms Pregnancy and Postpartum Resource Summit 2020. We are so excited to have Dr. Kimberly Simcox today, who's going to be talking about her topic is called Labor of Love, which I love. Compassionate care for pregnant women with substance use disorders. And we will take it away. So we have a number of questions that people over the last couple of days have emailed us. But we will also, if people kind of come on in and ask questions, we could take some live questions too. So take it away, Kimberly.
Okay, thank you. Well, hi, everybody. I'm so glad that I can present on a topic that I'm so passionate about. I'm going to be speaking on compassionate care for pregnant women with substance use disorders. I'm going to start with talking about how substance use disorders have impacted the world, how it's impacted us locally, how it's specifically affected women and pregnant women. I'm going to talk about how we manage substance use disorders in pregnancy and what you can do to help and how you can prevent it from affecting your children. I really wanted to focus a little bit on that because it's so important. So a little bit about myself. I am a Roanoke native. Local to Roanoke. I went to Patrick Henry High School. Go Patriots. Have a little street cred from there. I grew up in a time when a lot of people were starting to switch from just going to marijuana to going straight to heroin. So it was a really kind of frightening time when I was growing up, and a lot of my friends were affected by substance use disorders, and even as early as middle school, high school, and beyond. And it really became very personal to me when I became a mom, and I'm a mom to let's see. I'm trying to advance my slide. There it is. I'm a mom to a 6-year-old boy named Will and a 2-year-old boy named Wyatt, who's currently running around my house in the nude like normal. My other job is I'm an OBGYN for Carilion Clinic. But as you're going to learn, we have a major issue with substance use disorders in Southwestern Virginia. And then a large majority of my practice consisted of pregnant women with addiction. So I was able to become boarded in addiction medicine and concentrate my practice on working with women who are pregnant or postpartum with substance use disorders. So in case you are living under a rock, there's an opioid crisis in the United States. But you might not know that this is the third or fourth epidemic to hit the United States. And there have been several wars fought over this in world history. And I'm going to focus more on the opioid crisis today in this talk because I cannot address all the substances in 40 minutes. And they're, all of the substances, the trends model the opioid crisis. So I'm going to definitely concentrate more on that. But if you have questions on other substances at the end of the presentation, please let me know. I love to talk about drugs. It's a fascinating and horrifying subject. So as you may remember, Dorothy, Toto, and the Cowardly Lion, they were like traipsing through this field of gorgeous flowers on the way to the Castle of Oz. And then they all started to fall asleep. And the reason why they all fell asleep, because those were poppy plants, right? And when scratched, the poppy plant or the pod of a poppy plant produces a milky latex called opium. And that latex contains a variety of opioids like codeine and morphine. So I bet she slept just fine. So interestingly enough, around this time, L. Frank Baum, who wrote The Wizard of Oz in the late 19th century, there was an opioid peak at the time in the United States. So that was right around the time he was writing this for this movie. In the late 1800s, male doctors turned to morphine to relieve many female patients' menstrual cramps and diseases of nervous character, even morning sickness. It could also relieve yellow fever, cardiac disease, colds, dysentery, and excessive secretions. I can only imagine what that means. But at the time, women made up more than 60% of opium addicts. There was one famous product called Mrs. Winslow's Soothing Syrup. It was a morphine and alcohol concoction that was marketed to parents of fussy children as a perfectly harmless and pleasant way to produce a natural and quiet sleep, and by relieving the child from pain. After the Civil War, there are even more potent drugs that entered the market, including the opiate heroin, introduced by Bayer around the same time as aspirin, and the stimulant cocaine, which was used in everything from cough syrups to Coca-Cola. So, I mean, that's just a soothing lady. I mean, I could crawl up in her lap and take some soothing syrup. Anyway, but fast forward to the 1980s and 1990s when the FDA approved Lortab and Percocet. Purdue Pharma spent $207 million in 1998 to market OxyContin as a safe and non-habit forming alternative. In 2007, the federal government filed criminal charges against Purdue Pharma for advertising OxyContin as a safer and less addictive alternative than other opioids. Purdue Pharma and some executives then pled guilty, and they agreed to pay $634 million in criminal and civil fines. So now we know we have an even bigger problem with drugs such as heroin and fentanyl that are being imported into our country and even manufactured here. Fentanyl is estimated to be about 25 to 50 times stronger than heroin and 50 to 100 times stronger than morphine. About 2 to 3 milligrams of fentanyl can be lethal, and that's roughly the size of 5 to 7 grains of salt. And you may have heard of a drug that's even more horrifying just by coming or touching it or just by coming into contact with it, and that's carfentanil. And that is estimated to be 100 times stronger than fentanyl or 10,000 times stronger than morphine, and as little as 0.0002 grams can kill a person. So this is very scary stuff we have around here. And it's a lot of these, they even have synthetic opioids that are now not even detectable on drug screens. So it's horrifying. And one thing to add is that a lot of these drugs are used to lace into things like marijuana. And I just heard from a patient not too long ago that it cost them more money to get heroin because that's less lethal than it was to get fentanyl, which is really sad and just very scary. So for the first time on record, Americans are more likely to die of an accidental opioid overdose than a motor vehicle crash. The chance of dying from an opioid overdose is increased to 1 in 96, which surpasses the odds of dying from a car accident, which is 1 in 103. In 2018, 1,227 Virginia residents died from an opioid overdose. And this was up from the year prior. In fact, Governor Ralph Northam had visited Virginia Tech Carilion School of Medicine and addressed this problem to medical students and staff. And if you can see that like little orange shirt on the right corner of the screen, that is myself. I know right now that our emergency department at CRMH is now treating an average of 1 to 2 opioid overdoses every day. Many of you may have heard of the national best-selling book by author and Roanoke local, Beth Macy. This is called Dope Sick. She follows the epidemic's expansion as it crept up Interstate 81 from the traditional coal mining towns of southwestern Virginia to the suburbs of Roanoke. She describes a crack-turned heroin dealer by the name of Clifton Light Lee, who found that he could easily double his profits by importing drugs into the sleepy town of Roanoke instead of selling them. They were more available in New York and New Jersey. When the police caught 2 suburban teenagers middlemaning for Lee, and middlemaning is when you sell heroin to friends in exchange for keeping some for your own use, they were stunned by what they found and what the cell phones of these teenagers revealed. They had found evidence implicating about 50 other kids they'd been selling heroin to, and most of those kids attended Hidden Valley High School. By the time Lee was sentenced to about 11 years in prison, prosecutors had pinned him with bringing in 1,000 bags of heroin into the region 2 to 3 times a week, and he would pay $50,000 for 20 bricks of heroin that his network then sold for $30,000. And I also include Cave Spring in this image because I just had a patient the other day that said when she went there was a family that would cook methamphetamines at their home and then send methamphetamine bags into the schools with their young boys to sell, and they turned a major profit. And that really hits home because that's the school that my children are going to go to. And all the schools in this region are affected. I'm not just pinpointing these schools, but these are the schools that were addressed in the Dope Sick book. And I highly recommend that you watch this. The neighborhood pictured in the title and on the cover page is Cotton Hill. And she definitely talks about how it's gotten so bad in our area quite unexpectedly. So let's shift gears into understanding addiction. Like, why is this waging war on our friends and our loved ones? So this is a brain and it's trapped, right? That's a signal. It's like kind of represents addiction. What happens when your brain is attacked by this horrible disease? Decades of research have revealed that addiction is a disease that alters the brain. And we know that while the initial decision to begin to use drugs is voluntary, that drug addiction is a disease of the brain that compels them to become obsessed with obtaining and abusing drugs, despite their many adverse health and life consequences. Many people don't know that disease is characterized by compulsive behavior, continued use despite negative consequences, I cannot talk, persistent changes in the brain structure and function. A lot of people don't know that that genetics accounts for about 40 to 60% of a person's risk of addiction, which explains why I could take a pill and hate it, but you could take a pill and feel like the Jesus is wrapping his arms around you, as one patient of mine described it as. Furthermore, the environment a person lives in can impact their gene expression. This is a multifactorial disease. The vast majority of my women report a family history of addiction. In fact, some started using with their parents. Most of our women have a history of trauma, rape, abuse, are poor and uneducated. The genetic predisposition and environmental impact on genetic expression explains why this hits some patients so hard and not others. But I will tell you, this is a disorder that does not discriminate, and you can't really tell who uses substances. It does not discriminate from one economic demographic to another. And as you may not know, is that the relapse rate for this is 40 to 60%. So relapse is a part of addiction. It is not a failure. And this relapse rate is similar to the relapse rate of other chronic diseases like diabetes and hypertension. You have a good hemoglobin A1C if you're a diabetic for a couple months, and then it's not so good, right? Very similar to addiction. Now we're going to shift gears to babies. This is my young little baby Wyatt on like postpartum day 1. He's so cute. So we're going to switch gears a little bit to women and children. The gender makeup of the opioid crisis is changing, and women are starting to burden more of this phenomenon. As we touched on before, the opioid crisis is maturing with more people switching to heroin, less people using prescription drugs, and women are currently stuck in the middle with higher rates of increase in heroin use and lower rates of decrease of prescription opioid use. So what happens when women use substances in pregnancy? It can lead to fetal growth, fetal abruption, fetal death, preterm labor, meconium passage. But what we're more likely to see are the behaviors associated with its use. Women that use substances during pregnancy, any substance, are less likely to seek prenatal care. They're more likely to contract infectious diseases like hepatitis C. About 3/4 of the women in my program have hepatitis C. They have an increase of polysubstance use. I would say this is tobacco use is reported at 93%. I'd probably say it's 99% in my program. They have higher unplanned pregnancy rates, as high as 70%. Opioids in particular can affect a woman's menstrual cycles, so they might not know that they're pregnant. They most have co-occurring mental health disorders. 60 to 80% report past year intimate partner violence. And about 50 to 90% report a childhood trauma history of physical or sexual abuse. So this is staggering and very scary. Pregnancy is a time for positive behavior change. It is a motivating time for women to want to get pregnant. So there is something good. There's a silver lining here. As compared to non-pregnant women, pregnant women drink less alcohol, smoke fewer cigarettes, and use fewer illicit drugs during pregnancy. As the gestational age increases, the substance tends to decrease, which is wonderful. But Our women with substance use disorders have quite a large amount of shame associated with their disease and a lot of stigma, right? We typically look at women that abuse substances, and this is the image, the bottom right image is what we see. We consider addiction to be a moral failing, right? They deserve punishment, as in the top left corner, right? But we don't look at a diabetic that doesn't use their insulin during their pregnancy, which is arguably just as dangerous. We don't look at them and tell them that's a moral failing and that they should be in jail, right? So we need to shift the way we are thinking about this disease. Remember, it is a chronic disease whose symptoms are behaviors, right? So a lot of people think, well, they could stop if they wanted to, and it doesn't work like that. Your brain needs to heal, and we're going to talk about how we manage it. We need to instead focus on the faces of recovery. We need to change the narrative. We need to educate ourselves to dispel myths. We need to use medically appropriate terms. We shouldn't be calling people clean or dirty. You're not dirty because you smoke marijuana and it showed up on a drug screen, right? I mean, how demeaning is that? Are those terms? We need to recognize our biases. We need to use open and non-judgmental style when talking to our patients, and recognize that these are these strong women that are trying to do the best that they can and become the best mothers that they can. So, how do we treat this disease in pregnancy? Well, opioid use disorder treatment is a little different, but these are basically the same principles for all substances. So we don't just, give somebody a magical pill and tell them you're going to get better, right? We have to combine medication for addiction treatment with behavioral counseling. And most substances are very much, most substance use disorders are very much treated with different types of behavioral counseling, be it cognitive behavioral therapy. The pharmacotherapy that we use for opioid use disorder is typically methadone or buprenorphine, and you might have heard of buprenorphine as Subutex, which is buprenorphine only, or Suboxone, which is buprenorphine and naloxone. Yes, I do use Suboxone in my program, and I do use it in pregnant women. It is now one of the leading things to use for opioid use disorder in pregnancy. And so these medications, they treat the underlying neurologic changes in the brain. They control the opioid receptors and helps eliminate withdrawal. Most people, when they're on these medications, they are not using to feel high. They're using to not feel sick. And withdrawal from opioids is horrible. It's like the worst flu you've ever had. It is fevers, chills, diarrhea, body aches, runny nose. I mean, it is horrible. So you can only imagine how hard that would be to come off of. These medications, these long-acting medications that bind the opioid receptors, they stabilize the intrauterine environment. They reduce repeated opioid withdrawal, and therefore that's a more stable environment for the uterus, the fetus. So they're not going through this cyclic withdrawal, which can lead to stress. Detox is not recommended in pregnancy. So if we have somebody that's using opioids in pregnancy, we're not saying just come off of it, because it doesn't work. It's very hard to come off when you feel so bad and your brain is so altered by the use of these substances, where you can't make good decisions because of the damage that that particular drug has done to the brain and the neurodevelopment. So we actually we put patients on these medications because if they go off too quickly and their brain's not healed, they're going to return to use in most cases, and the outcomes are far worse if they return to use onto other substances. So for medications for addiction treatment, it's not replacing one for another. Medications for addiction treatment are long-acting medications. They help control an individual's craving to use, their compulsion to use the medication, to the drug, and it helps the individual regain control of their lives and helps them rebuild their lives. For moms, when women are in treatment, they're more likely to go to prenatal visits, and they can also be linked with for treatment with for HIV, for hepatitis C, to reduce the likelihood of transmittal to the unborn baby. They tend to have better long-term health outcomes for the mom and the baby. There's a wonderful study that kind of it's called the Mother Study. It was the primary investigator of this study was Andre Jones from UNC, and she had a large randomized controlled trial where they compared pregnant women that were not in treatment to pregnant women that were in treatment on methadone and buprenorphine, and they found that the women that the babies that were born to women that were in treatment had lower risk of neonatal withdrawal, less severe symptoms of withdrawal, shorter treatment times, and higher gestational age, weight, head circumferences. And when I mean shorter treatment times, that's less time in the hospital for neonatal withdrawal treatment. But still, Dr. Simcox, what about the baby is what I hear. A lot of patients are just like, well, if I just kind of taper myself down and then it's going to be great for delivery, the baby won't go through withdrawal. I mean, I understand that need, but like a lot of these people, when they present to me, they are using heavily and they do not have the decision-making capability to at that time, and their brain is not healed enough to really be successful off of any medication or out of a program. So we have, at the end of the day, pharmacotherapy, it works, and it works best if it's provided long term, including throughout pregnancy, just like many other chronic diseases, right? Infant withdrawal, it's an unfortunate but predicted condition with medications for assisted treatment, but it's temporary and it's treatable and it's expected. Whereas the effect on a family from a mom dying from an overdose or a drug related issue is life lasting, right? We shouldn't be thinking like 9 months down the road, like when the baby's born. That's just a very small window into the rest of your child's life. We need to be thinking 9 years down the road, 19 years down the road, 90 years down the road, when have your wonderful children that are really bad, like Wyatt, my 2.5-year-old. We need to be thinking like down the road, because mothers are the best things for their children, and they need to be in treatment so they can continue to be the best moms that they can be. So what do we do at Carilion? What do I do every day? Well, I have a program. It's called the Carilion Women's Emerald Program. And the top left is Dr. Wells, who's speaking right now on maternal depression. So you need to check out her webinar. She's fantastic, hilariously funny. She currently has pink hair for Breast Cancer Awareness Month. But I work with her. She's a psychiatrist that is also trained in OBGYN. The top right picture is my care coordinator, Leanna Stone, who I love and worship. She's also an LCSW and basically my therapist. And then to the right is Charlie Teresides, who is this clinical pharmacist that everybody loves and is very passionate about this patient population. So I'm going to attempt to show you the video, because I don't want to just talk about what I do. I can show you a very motivating video. So let's see if this works. Jackie, tell me if it works. Can you see anything?
Not yet, but I think you have to share a different screen.
Measuring methadone by the drop is not.
1 second, everybody. Technical difficulties.
It will work if you.
I'm going to screen share. Do I do a new share?
Yep.
All right. Here we go. All right. Share.
Yep.
Sweet. Okay, here.
For the Marlowe family fostering this baby girl, measuring methadone by the drop is not something they necessarily planned for.
We got a phone call one Thursday morning saying that there was a baby who had been born and who was dependent and needed a place to live.
Carilion Clinic's programs for caring for opioid-dependent babies and their moms have evolved since we met the Marlows to include even more services.
We collaborate with pediatricians, we collaborate with emergency medicine physicians, and outside primary care providers or other obstetricians.
Our typical mom of our babies that are at risk for having withdrawal, she is first-time mom. She was using heroin, found out she was pregnant, got into a treatment program, but this is her first pregnancy, it's her first baby, and she's only been in her treatment program for a few months. So there's a lot of firsts there.
I met the mother of a baby who was dependent. And when I met her, literally my heart broke. I had to excuse myself and go into a private place and because I realized that she was very much a victim to.
Since many substance use disorder programs won't allow women to remain in treatment once they become pregnant, Carillion's office based opioid treatment program is one of the only options for continuing their recovery journey. For the babies, treatment in the hospital has changed so that in many cases, medication is no longer needed.
So having either mom's room or transitional nursery, it's dark and quiet. So just as low stimulation environment as possible.
It takes all of us working together to create a brighter future because no one chooses addiction.
Addiction is a chronic relapsing disease. A lot of people don't know that. Shame is toxic. It doesn't promote change. So we have to start treating each other more kindly. And we have to choose to get educated and make better decisions for ourselves and the people around us.
The Marlowe family's foster baby is doing well 1 year after they got that call and has been reunited with family. Karen McNew for Carillion Clinic.
Okay. Stop share. Let's do a new share.
I love that.
Isn't that so they didn't tell me.
Carillion Clinic's
Whoops, here we go again. You love it so much we can watch it again. They didn't tell me that they were coming on one of those days and my hair's like all over the place.
No,
So
it looks awesome. I love it.
All right, let me see if I can get back. Perfect. All right. Back to the show. So, you know, what we do in our program is we combine prenatal care and medications for addiction treatment. We have care coordination for our patients. We collaborate with other disciplines and we try to make a co-located care model for our patients. So I wanted to talk a little bit about what you can do if you're interested in this patient population and how you can reach out to these powerful women. There are some initiatives like the Hope Initiative in the Roanoke Valley. It's affiliated with the Bradley Free Clinic, who we love. If there are people that like to volunteer with people in recovery and learn more about the disease of addiction, this is called Angel Training. You can also donate to the Roanoke Valley Hope Initiative. So I have the website there at the bottom. Sherry Hartman kind of directs this. She's one of my favorite people in the world. She is Dr. Hartman's wife as well, and they're kind of a dynamic duo in the field of addiction medicine in this area. Bethany Hall is a place, it's a residential facility where women who are pregnant or postpartum can go to have a safe place to live and enter intensive recovery. They do take donations for clothes and children's books and, children's toys. It is a wonderful place and they house several of my women. So I'm a big supporter of Bethany Hall. They're like right there on Franklin Street. You can give them a call and see what they might be in need of. So what you can do is you can give to the Women's Resource Center, right? New River Valley and Roanoke. TAP or Tap into Hope is a domestic violence shelter and program for women that have been affected by intimate partner violence. The Rescue Mission has a program for residential recovery, the Paths Forward. And they also want donations. In my program, I am always looking for things like children's books or clothes for our women, children's toys as a reward for women when they have negative drug screens. It's a contingency management approach that we're using, and it can be very effective, especially with stimulant use disorders. So we are always looking for any help. Our women very much appreciate these types of things. Even very small things can go a long way with this patient population. So tips for talking to your children. I think the best thing that you could do is to talk to your kids about substances. Children are starting to use substances earlier and earlier and earlier, right? So now people are recommending, agents, American Academy of Pediatrics, they are recommending that we talk to our children about drugs as early as 4 to 7 years old. I mean, that's like my child, Will. I can't even imagine trying to have this conversation. I've tried, it's been interesting, but each time it gets better. You keep trying. They recommend that when you use medicine in the house that you talk about why you're using that medication, how it can be used only by the person who is unwell, and how sticking to the correct dose is important. If you have old prescriptions in your drug cabinets, you need to get rid of them. There are plenty of prescription take back programs. You could even take them to any Carillion pharmacy, and they have drug take back boxes that I highly recommend. Empty out your medicine cabinets so that children don't try to experiment with this. You want to repeat simple information about the dangers of drugs, smoking, and alcohol, and about the benefits of things like nutritious food, exercise. So you want to take a two-pronged approach. You want to tell them things that are not good for our body, and then some things that are great for us. And if you know that your child has heard of a hard drug, like on the news, right? Ask your child, do you know what that is? You'd be surprised. A lot of them do. And you want to tell them that the drug is addictive and it can severely harm their body and kill them, right? You want to talk to them about, be specific about what the drug can do, but keep it as simple as possible. If they want more information, give it to them. Watch videos. There are a surprising number of videos made for children on things like YouTube. So instead of letting your child watch like whatever the horrible things are my child watches on like Hobby Kids, they could watch this instead, right? If you give them screen time as a reward, you can combine this with that. And you want to just continue the conversation. Reach out to school counselors as to how you address this with your children. And look at the American Academy of Pediatrics website. If you have a friend or loved one that is suffering with substance use disorders, Substance Abuse and Mental Health Administration has a national helpline that you can link them to area resources. The Virginia Department of Health has a website with all the treatment programs in the area. It's very easy to find. You type in your zip code, boom, here are all the treatment facilities. I highly recommend that if you have a friend that's struggling but not quite ready to enter treatment, that they at least talk to a peer recovery specialist. Peer recovery specialists are people that have suffered with substance use disorders in the past, and they've gotten specialized training to help other people. So a person that's not quite in that kind of contemplative stage of getting into recovery, they might be too nervous to talk to like a doctor. I mean, we're kind of scary sometimes. They might be more willing to talk to somebody that's been through them themselves and are less likely to feel judged. So I highly recommend the peer recovery specialist, and their hotline number is right here on the website. Right here, it's 491-4878, and I give that hotline number to all of my patients. Also, just as an aside, make sure people have Narcan. There are Narcan dispensaries everywhere. The Harm Reduction Coalition is a huge supportive organization that is just working on harm reduction and primary prevention through clean needle exchanges and free access to Narcan. So I highly recommend you look up the Harm Reduction Coalition. They even have a wonderful pregnancy toolkit for you to use that can give any patients that have substance use disorders and are pregnant, has tons of information, and I give copies of those to my patients. So what's the takeaway? Pregnant women are very motivated to maximize their health in pregnancy. So this is a perfect opportunity to get them help. If they can't stop their use of substances during pregnancy, they have a substance use disorder and they need treatment, not just saying no, like old Nancy Reagan used to say. Bless her, they need treatment. Addiction is a chronic relapsing brain-centered disease whose symptoms are behaviors. And giving their unique signs, pregnant women deserve our compassionate, non-judgmental, coordinated care. So don't just sit there, do something, right? And talk to your children, talk to them now. If you know you have a substance use disorder and a genetic history in your family line, tell your child, if you try this, you're going to like it, and this is going to be a problem for you. So don't even try them, okay? So those are my biggest pieces of advice, and I can't even tell you how rewarding this patient population is. They are the strongest women I have ever met. They have been through unsurmountable obstacles and still trying to be the best that they can be for their children. So please be compassionate, be kind, and get educated. And that's my presentation. I think Jackie's trying to talk to me.
Yeah, we have some questions that have come in. We only have 3 minutes left. That was such a great presentation. Thank you so much, Kim. Are there any legal implications with
Yeah.
people entering the addiction program? I think that's the biggest apprehension for patients out there that,
Yeah.
are addicted and then all of a sudden they pee on a stick, they find out they're pregnant and they want to get care, but they're nervous about legal ramifications.
That is, couldn't have planted that question better myself. That's fantastic.
Yeah.
So one of the things we talk about in our program are what this means when they deliver, right? There, unfortunately, in Virginia, is a mandatory report when children are substance exposed that come in for delivery.
Okay.
But if a woman has been in treatment, right? If she is already engaged in case management with social workers, they do, yes, the social workers in the hospital do have to report to Child Protective Services. But if they're already engaged in treatment, they're less likely to be affected by that, right? Child Protective Services, their goal is not to take your baby. Their goal is to make sure your children are in a safe place. If you have a pre-existing case open or something, they may be involved a little bit longer. But I mean, I have rarely had women where their babies were taken, and if they were, it's because didn't get to them until they delivered that day, and they weren't really in treatment. That's the only time I've really seen it, when they have not been engaged in treatment.
Yeah.
So I mean, that's not the goal. It's get treatment, get a support system. Child Protective Services, they're not the enemy. They have tons of resources to hook women up with, for parenting classes, formula. I mean, they're an amazing resource. We just have to start thinking of them like that and not be afraid of them. Actually use them and use their resources.
Thank you so much. So I think, we only have 60 seconds left, but I just want to drive home, as an obstetrician myself and, working with Kim, we really encourage the moms out there that if you think that you have an issue of any kind, don't feel ashamed, come seek treatment. Overall, there's, this program is meant for you, and we've done a number of things. Kim has done a number of wonderful things at Carillion to really build up this program from scratch and really take care of this specific patient population. So we're so excited. Thank you so much,